Hi, everyone, and welcome back to 1 Minute Consults. Today, we're joined by Dr. Benjamin A. Udelman, who is a director of thoracic aortic surgery at Maimonides. Welcome, Dr. Udelman.
Well, hello there. How are you, Adam?
Yeah, it's good to see you. So, acute type A dissections. What do we need to know?
So, patients come into the emergency department with acute symptoms. You think it might be a type A dissection. The things you want to think about are acute onset of symptoms and whether they have any malperfusion syndrome. The way to assess malperfusion syndrome would be mental status from above. Obviously, those are the head vessels. Then it's going to be upper extremity pulses, upper extremity physical exam, lower extremity pulses, lower extremity physical exam, warm, cold, things like that. And then obviously, you can sometimes have patients that have migrating symptoms. They initially had this severe onset of pain. Maybe their leg went cold or even fell out from under them. And these are the first things you want to ask.
What about what should we specifically check during the physical exam?
So you want to do pulses on the distal, upper, and lower extremities. Blood pressure is also very helpful. Malperfusion usually presents, as we all know, as a 20-point difference between the extremities. And if patients have mental status changes of any sort, then that would be concerning for either carotid or vertebral artery involvement.
What about family history?
So, family history is a question that's obviously rarely asked in the acute setting. I instruct a lot of paramedics that I feel that this is important for them to learn. Um, they learn the sample, SAMPLE, and I told them, why don't you change it to sample the family? Because when they go into the homes, they could ask the family any history of aortic dissection, aortic aneurysm, aortic rupture, unexplained sudden death, or cerebral bleeds. These will all point to some sort of family history, connective tissue disorder, which we all know is not the big six we learn about in medical school, or in my case, there was only four. Now we've got, numbers of genes in the 30s, a few more years will be in the 50s. And really, we all know that only 20% of the patients have a named gene associated with their aortic condition on testing, not so common. So all the things we learned in medical school to some degree have to be put aside, and we have to think about it in terms of any patient with sudden onset chest pain who has a strong family history, who has a sign of malperfusion. Very, very high on the list would be aortic dissection, and they need to go off to the CAT scanner to get a contrast CT.
Any special considerations, Dr. Udelman?
The one thing that we all fear are patients that come in that have a condition like aortic dissection, and we have a Jehovah's Witness that we have to have a conversation with, and tell them, well, it is very, very unlikely that I can get you through this operation without a blood transfusion, especially when the patients are starting with a fairly low hematocrit. And so those are things you need to ask up front, and you need to find out what patients' goals of care are. Besides that, patients who are on blood thinners, who are going into an operating room for an aortic dissection, that's really going to be big trouble. So you have to figure out how you can mitigate these types of situations. In one case, obviously, Jehovah's Witnesses, you might want to delay the operation if possible, keep them under very, very intense surveillance, or look for an endovascular approach if that's even possible. The second, patients who are on blood transfusions, who are on blood thinners, you might have to figure out whether you can reverse them, whether you can reverse it successfully, and what you can do to balance that risk, which is quite significant.
Wonderful. Thank you very much, Dr. Udelman.
It's a pleasure.